Do you think that the American public is under the impression, to the extent they get the issue at all, that comparative effectiveness is not so much about the cost of the product, but more about how it will benefit them? You cited the example of atrial fibrillation and whether or not there's really any advantage to having an ablation procedure or managing the condition through drugs. I think that probably what the public believes is going to happen is that the government is going to invest, I've forgotten what the number is, but it's a big one, lots of money in comparing different kinds of treatment and perhaps diagnostic modalities. And yet, from the discussion we've had, that really is not quite that simple. It is clearly going to have something to do with costs, I assume. Is that a fair comment?
Sure. I think that there's overlap. I think it's a Venn diagram. I think that as a clinician, those of us are thirsty for the evidence with which to make the decision. And would love to do it in the absence of the discussion about economics, but obviously that's impractical and can't do that. I do not think that, I think that putting it into a purely economic context is an oversimplification. And just in terms of the value that it's going to provide.
Right.
I think it's, you know.
Well, of course, the history of comparative effectiveness research in the U.S., I believe its life began as cost-effectiveness research, and it was relabeled somewhere along the path. As I said before the meeting, kind of the way death insurance was relabeled life insurance. And the comparative effectiveness allegedly is not going to be used to make decisions that are based on cost. But clearly this is something that I think the public may or may not understand. Please.
Sure, but I mean, I think that within this huge umbrella and the additional, you know, $1.1 billion that have now gotten allocated to CER are a lot of studies that will impact in the broader healthcare dollars, but not necessarily on products. Yeah. There are already studies, large federally funded studies within this funding mechanism that are looking at comparing surgical types of techniques for very common conditions such as leaky mitral valve. Sure, there are some products that have developed along the way that are used in the operating room, you know, as part of these techniques, but it really is going to, it will provide doctors and patients the ability to make an evidence-based decision about which direction to head.
Andrew, did you want to add?
Just reflecting on Thomas's comments, and I think it's a mistake to see CER simply as a kind of pricing mechanism. It's certainly the case if you use an economic evaluation to make a judgment. You need clearly price is a critical element to that.
Is his microphone on back there? Yeah. Can you get? Thank you. Sorry, I didn't mean
so it's not simply a pricing mechanism. You can use it as a means of making sure that resources are being applied as effectively as possible, and you can be explicit about that as NICEs by expressing part of the justification for the recommendations we make in those terms. But the important part, the really important part of this process, is that judgment about the incremental therapeutic benefit for patients. And whilst it's true that if you're transparent about the way you go about things as NICEs, if you have a kind of threshold of cost effectiveness, so people have a sense of what's going to work in the healthcare system, what's going to be regarded as value for money, then it isn't surprising, after all, we're all human beings, that manufacturers will look at that and say, how can we maximize what we're going to get for this product in that healthcare system and get it into, in our case, into the United Kingdom. So there is going to be a bit of a bunching around the critical points of inflection in any kind of cost-effectiveness threshold. But then you have to look at the detail. The detailing is what's important in what NICE puts out. We don't just say, here's a product and it's cost-effective or it's not. we produce a piece of advice for clinicians which helps to inform the judgment that only they can make with their patients. It's not an instruction to them to practice at all. NICE is advisory in the NHS. But we go into considerable detailing about how to position that technology in the armamentarium available. What works? Where does it work? Where does it really score compared to the treatments that we've got currently available? So it does that important job for clinicians about giving them a starter in terms of whether this is the right product to use for this patient at this point in time. And we can help the health system more broadly, particularly those who've got responsibility for the stewardship of the resources, with advice on whether or not this particular product used in these circumstances represents good value for money for the system.
Thomas, you indicated that when the private sector does these studies, they tend to overstate the benefits and underestimate the costs. We have $1.1 billion going to be spent by the U.S. government on these kinds of studies. And when I checked the Washington Post this morning, it seems that we still have a significant economic problem. We have a great interest in reducing the deficit. It's hard for me, call me cynical, that our studies are going to ignore and not pay attention to the cost issues involved with the delivery of health care. And I think that perhaps the reverse will be true with government, and that is that they may understate the benefit and overstate the costs. But we'll have to see how that plays out in reality. There's a vast cultural difference, of course, between the United States and the UK, which is actually a civilized place. That was an attempt at humor. The United States model is a little bit more competitive. We have branches of government that compete with each other, and even members of the same party now are busy competing with each other. And it's a very tense and dynamic kind of conversation in this country. And perhaps all of that will work to bring to the patients and to physicians a balanced picture, or at least sufficient data that they can select that which they might be able to draw upon for their benefit.